right, so welcome to this year's O'Neill Institute World AIDS Day event. This is an annual event that we've done, or at least that I've done since 2016. I've been at the O'Neill Institute for 5 years, and I've done this every year since 2016. And I wish, I guess normally we do it in person. And so I do miss having that kind of in-person contact, but I hope that we can still have both a good presentation and a discussion. For now, I've muted everyone's microphones, but hopefully during the discussion time, we'll be able to either get some live questions so people can unmute themselves, or you can just put questions into the chat box at any time, and I'll make sure that I respond, or see if anyone else on the call might have thoughts and may want to kind of chime in as well. Again, this is a virtual format this year. And I think actually there's at least one of the benefits, I think, to the virtual format is that I think it has allowed more people to be able to join for the event. So I think in past years, we usually have an audience of maybe about 10 people. And I think this year we've already have about 40. So that's wonderful that this information hopefully can reach more folks, and that we can, particularly on this topic, have a more focused attention on it and really have the types of discussions that we need to kind of move forward on these diverse issues. So again, the topic for the presentation today is decriminalization is critical to protecting marginalized people and creating a healthier world. Lessons from HIV and COVID-19. My name is Sean Bland. I'm a senior associate at the O'Neill Institute, where I predominantly work on US HIV law and policy issues. And so for this topic, we're going to obviously be learning from the HIV experience, and then also thinking about some more recent issues in the context of COVID-19. So here's an outline for the presentation. I'm going to provide an overview of the O'Neill Institute very briefly, just so, particularly for those who aren't as familiar with us, just so you know who we are and the type of work that we do. I'll then get into really the content of the presentation, which will be on criminalization of health status, so specifically HIV and COVID-19, and then talk about criminalization of sex work and drug use. And for each of those 4 topics, I'll give an overview of what criminalization looks like and some of the evidence around what the impacts on health and other issues are. But then I'll also really focus on kind of recent developments, specifically recent efforts to decriminalize in each of those areas. And then we'll also have time for questions and discussions. And I'm hopeful that we'll have, around 30 minutes or so for that. And I really want to kind of make sure that that can really be a really productive time for us. And so I want to kind of tee up some of the issues that I would expect to come up during the discussion, questions that might be asked. So the first one I think is really critical in terms of really where do we go from here? And I'm really excited about the kind of the diversity of folks who are on this Zoom call today. So I've reached out to a number of different organizations, student groups, networks, working in different areas. And I think we have a diversity of people on the line. So a number of folks from the HIV community, so folks who are care and service providers, researchers, policymakers. I think there might be some representatives from health departments represented here, as well as just advocates, policy advocates, and advocates on the ground. We also have, I think, at least 1 or 2 folks who are involved in kind of community-based harm reduction or sex work advocacy. So it's excited to have that perspective also, I think, represented on the call. And then I think we have a number of people coming from Georgetown Law Center, which is where the O'Neill Institute is based. So law faculty, staff, so including attorneys, as well as law students. So folks who are getting legal training to kind of do legal advocacy in their communities. And then we also, I think, hopefully have a few folks internationally. So O'Neill does a lot of global health work. So I know that at least some folks who RSVP'd are outside of the US. So I just think that there are a diversity of experiences where, at least in this discussion portion, I think we might be able to learn from one another, learn from strategies and approaches that have been adopted kind of in the area that you're working in or in the part of the world that you're working in, and share that with others. And really to just kind of strategize around coordinated action. So if you're working predominantly on HIV, how folks in HIV can be supporting work, sex worker advocacy, how sex workers can be thinking about leveraging relationships to the legal experts and engaging the HIV community so that we can have a more coordinated focus around decriminalization. I also hope that we'll be thinking about decriminalization as a racial justice issue. We know that policing, arrests, and incarceration disproportionately impacts racial and ethnic minorities, specifically Black and Brown people in the United States. And that's also the same for HIV and COVID. People of color in particular are disproportionately impacted. And this is due to systemic racism, as well as a number of other social and structural factors, including poverty. And so I don't think we can have a discussion about decriminalization unless we recognize that fact and really approach this issue from a racial justice lens and make sure that we're centering people of color. And when I'm thinking about centering people of color, I'm thinking about making sure that people of color are having the opportunities and are really leading a lot of the efforts around these issues. So hopefully everyone on this call has something to contribute and can be leaders in their own right, but there also will be some times where it's important to kind of step back and to let some of the most impacted communities really kind of lead some of these discussions. And it's important to kind of listen to the ideas and the solutions that they have as well. And I'm really hoping that we can, in the third point, break down silos. So again, I'm going to be talking about 4 distinct but also related issues: HIV criminalization, COVID criminalization, sex work criminalization, and drug use criminalization. I hope that in how I present and just by bringing them all together in one presentation, it will really focus that we really need a broader shift in our mindset to focus on decriminalization generally. So it's not just an issue-specific decriminalization. We need to be thinking about just how we can decarcerate and decriminalize kind of more broadly. And that kind of relates to the 4th point on the slide around sustaining decriminalization efforts. I think there have already been some successes, or at least some changes in policy with respect to decriminalization, but those changes in policy are not the solution. They're not going to just happen and then all problems have been solved. So even where we've seen decriminalization implemented in certain cases, so in the US, we've had decriminalization, for instance, of marijuana use here in the District of Columbia, where I'm based. We've had decriminalization of marijuana for a number of years, in part because DC is the federal district, so we are under congressional oversight. That approach was taken in a certain way. So we didn't decriminalize everything. So you can access marijuana, you can grow it, you can have a certain amount for personal use, but buying and selling it for a significant amount of money, or really any money, is still criminalized, as is the use of marijuana kind of outside of your private home. So if you're in a public space and you're smoking, you can still be criminalized. That continued criminalization, even though we have implemented a form of decrim, still leads to a lot of policing and arrests, and disproportionately that policing and arrests is targeted at and impacts Black people in the district. And so in many ways, we actually are seeing greater disparities in policing, arrests, and incarceration around marijuana, just like other drugs. And we're actually seeing greater ones now with marijuana in some cases, because the people who are coming in contact, either smoking on the street, so folks who might be homeless or unstably housed, might not have a place where they can do it. If they're in public housing, there might be, they might be prevented from doing that on that, in their units or in their property. They're on the street, and so they're coming in contact with law enforcement and still being criminalized. And so it's important to kind of think about, even as we have successes, that criminalization kind of still takes different forms. And I think we see similar things in other parts of the US. Some of the states that first legalized marijuana use for personal use, states like Washington State and Colorado, we still see arrests targeting of particularly people of color for marijuana use, even though it's legalized for people to use. And most of that kind of arrest happens because, again, people have too much for whatever the limit for personal use is in that state. And then lastly, I want to also, and I hope, again, that these are all things we can have in the discussion, and please feel free to put things in the chat now, and we can make sure that others can maybe respond, and then I'll also take a chance at responding, a stab at responding at the end. Is really just thinking about the relationship between decriminalization and really rethinking investments in the police. I wouldn't want to have this conversation without really making sure that it's connected to conversations that are happening in communities, demands that advocates are having. And so those are conversations about how we allocate resources. So making sure that we, on the one hand, we could just be reallocating resources, putting more money into health services, mental health services, social services, rather than policing and incarceration. So making sure we increase around that service delivery. But it also could mean, at least in some cases, it doesn't have to mean this, but it could mean taking money away from policing and putting that money into the places where we actually know we have evidence-based interventions and approaches. And so, again, when we think about that kind of taking money away from the police, that could be, again, recognizing just what the evidence says is most efficacious. It also could be just recognizing the harms that police are that they commit in different communities, particularly in communities of color. And so recognizing that having less police and less policing could be a valuable thing. And then similarly, moving from allocation of funds all the way to conversations now that I think have received a lot of attention around defunding the police and what that means in terms of really reducing police budgets as much as possible, possibly down to zero, which I think is a very scary proposition for some folks. I think it's important that we, one, have an understanding of what that means, and hopefully we'll have some more evidence around that as well. But really to kind of take that and kind of understand that, and again, some of that that's going to be beyond the scope of this discussion, but again, of my presentation, but hopefully it'll come up in the discussion. We're thinking about defunding the police. Some of these questions are political questions. How feasible is that? And again, it's not going to be feasible everywhere, politically feasible at least. But then even separate from that, there'll also be a political question around how do you even frame some of those discussions. So again, defunding won't happen overnight. You'll be reducing funding over time, possibly. Should you use the word defunding? Should you use reallocation? Should you use whatever word that you think is going to, and those are decisions that I think politicians are going to have to make, and that advocates also are thinking about and figuring out the best way to kind of share that message out there. But I want to make sure that that's something to keep in mind, and that we also have some time maybe for discussion around that as well. So now I'm kind of moving into the discussion. I'm going to make sure that, again, I'll give you first an overview of the O'Neill Institute and the research, the evidence base that we kind of work towards, because I want all the information that we're talking about to be evidence-based, which is, again, what we O'Neill Institute really focuses on in our work. So introduction to O'Neill. We are predominantly lawyers. So I'm a lawyer. I graduated from Georgetown Law Center in 2013. Again, I've been working at O'Neill for 5 years. Our work is at the intersection of health and law. We work in a number of different areas, not just infectious diseases, so food and drug law, global health policy and politics, health and human rights, the law of international development. And then, as I mentioned, infectious diseases, so that includes HIV, but also hepatitis, most recently COVID. We're doing a lot of work around COVID. And then we also have an addiction and public policy initiative as well. And our approach really is to integrate scholarship, policy, and practice. And so when I say scholarship, I'm really thinking about work that is very traditional academic work. So studying complex issues and then publishing about them in public health or medical journals or law reviews. So that's something that we do a lot of. Still, the bulk of our work is in our research projects, and that's really meant to bridge the kind of scholarship, the academic scholarship, to real world impact. So those are funded projects that focus on particular areas. And then we also do a good amount of capacity building, which is around building future leaders. So making sure that lawyers are trained around health issues and making sure that we talk to folks outside the legal area, outside the legal profession about what role law and policy plays in the context of health. Just in terms of our HIV/AIDS initiative, which is what I work on, we do work particularly in 3 different buckets. So HIV treatment is a big area. So a lot of that work is focused on the Ryan White HIV/AIDS program, which is a federal program in the US to provide medical care, prescription drugs, and support services for people living with HIV who are uninsured or underinsured. And so we do a lot of work thinking about how do we sustain and adapt that program over time, particularly as the health system changes. We do a lot of work on HIV prevention, so particularly around access to things like pre-exposure prophylaxis or PrEP, post-exposure prophylaxis or PEP, syringe services programs. In recent years, we've done a lot of work looking at the development of long-acting HIV prevention and also long-acting treatment, and thinking about policy issues there. And a lot of our work is focused on, again, priority populations. So in the context of HIV, that's in particular gay and bisexual men, trans individuals, and people of color in particular, as well as people who use and inject drugs. And then kind of the third bucket that we work in is the intersection between HIV and criminal law, which is really kind of where this presentation comes from. So work on HIV criminal law reform and sex work decriminalization. And when we do our work, we often consult different stakeholders. We hold a lot of consultation meetings with stakeholders to learn about different issues. We do our own background research into the scientific literature, into policies, into laws, and then we develop resources, so issue briefs of different lengths and different formats. You can see the different types of documents that we have. All of these are available on our website under our infectious disease initiatives. And so, yeah, we get out our ideas, synthesize issues, and make policy recommendations. So just in terms of our first area, HIV criminalization, I really want to just make sure that when we're thinking about this issue, we really are just kind of reframing how we think about it. So thinking about it in terms of how we can promote public health. And when we think about it in that way, we realize, and I think it becomes evidence that the current criminal laws that exist in the US and in many other countries throughout the world really do conflict with public health goals, and they expose conflicting values. So it's just good to keep these questions in mind as I present, and particularly when we get to the discussion as well. Are the laws scientifically valid? I think one of the main purposes behind rationales behind these laws is that they actually help the HIV response. They help to prevent HIV transmission. At least that's what is put forth as a rationale. Is that true? Like, what does science say about that? Are we actually preventing HIV with these laws? Particularly since these laws contribute to stigma, and they may lead to other public health consequences. That includes whether or not they encourage or they discourage people getting tested or engaging in care. So a major, for all of these laws that exist, you need to know your HIV status in order to be criminalized. And so what that leads to, I think, is that people not knowing their HIV status won't be criminalized. So does that disincentivize people from wanting to get tested and knowing their status? It could, and so those are questions that need to be addressed. So not just, are we generally preventing HIV infections, but hey, what are some of the impacts on things like testing and engagement and care and stigma? When we think about the laws that exist, what kind of legal state of mind, what's required for the law? What do lawyers have to prove? What do prosecutors have to prove? Do they have to prove that there was intent to transmit HIV? Do they have to prove that an individual was being reckless, that they were being negligent? So thinking about what is the right kind of mens rea or state of mind that should be in these laws. And then thinking about how can courts actually determine whether disclosure is made. A lot of HIV criminal laws really turn on the issue of disclosure. So did the person living with HIV disclose their HIV status to their sexual or drug using partner? That's a factual question. Those types of things would generally go before a jury. In the US, many cases never reach a jury. They often go to plea bargaining. But where they do reach a jury, how does a jury kind of come to that conclusion? Yes, disclosure was made, or no, particularly in a context where it may just be, he said, or she said, he said, a scenario. So it's just two different people kind of saying different things. How do you determine who's credible? Often, I think juries put themselves in the position of the person not living with HIV. And so in many cases, I think we've seen lots of convictions of people living with HIV when we get to the point of actually having a jury trial. Another I think key issue to think about is around safety. Is it safe for a person living with HIV to disclose their status? We know from research that many people living with HIV, particularly women, experience violence, so domestic violence from their partners when they disclose their status, so either at the moment of disclosure or sometime after. So thinking about those safety concerns, I think it's important just to keep in mind. And then lastly, just thinking about whose responsibility is it to prevent HIV transmission? Is this something that should be the responsibility of both consenting partners, or is it solely on the person living with HIV? So just to make sure we all are on the same, have the same baseline, what is HIV criminalization? So it refers to, make sure I'm not skipping ahead. It refers to the use of criminal laws to penalize people living with HIV for HIV non-disclosure, so not disclosing HIV status, or for exposing or transmitting, exposing someone to HIV or transmitting HIV. As I already mentioned, at least in the US, and I think in many other countries, a lot of these laws turn on disclosure. So they require people living with HIV to disclose their HIV status prior to having sex with a partner, for instance. These laws, in most cases, and definitely in the US, in most cases, they do not require intent to transmit HIV. Um, so it is simply enough that you just didn't disclose your status to a partner that you could be prosecuted and possibly convicted. They don't require actual transmission, so it does not have to be the case that your sexual partner or your drug using partner actually contracted HIV. That's not required. So there may be no HIV transmission at all. And in many cases, there may be little or no risk of transmission. So we see cases of criminalization for things like spitting, where there's no chance of transmission, or even for oral sex, where there's no chance or very low chance of transmission. And so these are contrary to science, but we're still seeing a number of these cases. What's going on in the United States? Well, in the US, we've had over 300 arrests, charges, or prosecutions since 2008. So in just over a little over a decade, hundreds of people have been impacted. And again, this is probably an undercounting because there's not like a central database to know all the times in which these laws are used, but they are still being used even in recent years. 32 states in the US have HIV-specific laws that apply only to people living with HIV. And other states also use general criminal laws to prosecute people living with HIV based on their HIV status. So this raises the question, even if you were to like abolish HIV-specific criminal law, so repeal all of those laws, there could be the possibility that states might try to use their general criminal laws, so things like assault statutes or reckless endangerment statutes, to prosecute people living with HIV. That possibility, I think, has led folks like myself and other legal professionals to really advocate for modernizing our HIV criminal laws. So really changing them to make sure that they are not inconsistent with science, and also making sure that they are very narrow. So the types of behaviors that can be criminalized are so narrow and really focused on intentional transmission, which I don't know how, we'll give you some data around the risk of transmission later, how often that really can, if these laws are written in a certain way, how often, criminalization would even be possible. But really kind of focusing on that as being how we should be reforming laws, and again, leading to less criminalization, decriminalization. We also, again, we have 11 states that make it a crime for a person to live with HIV to spit or bite. And a lot of those types of cases often come up in the context of police arrest. So when someone's resisting police arrest, they might physically try to resist, but they also might spit or bite. And if a police officer or someone else later finds that that person's living with HIV, they could be criminalized. And again, we're seeing prosecutions recently in the last 4 years in 33 states, there have been at least one prosecution. And in some states, punishment can require registration as a sex offender. So these laws have a significant impact, not only in terms of time in jail, but even once you get out of jail, having that sex offender kind of label on you for years, or if not for the rest of your life. Just giving some examples of criminalization, again, in different states. So a man in New York was sentenced to 10 years for aggravated assault for biting a police officer. It's a very significant sentence. In Iowa, this was years ago, Iowa has since changed its law, but just giving you a sense of the type of sentence, and we'll talk about what that reform looked like in Iowa. There may even be someone on from Iowa to kind of share some of the experience there. But a person in Iowa who had an undetectable viral load, so we know when you have an undetectable viral load, you can't transmit HIV to your partner, to your sexual partner. That person was sentenced to 25 years for a one-time sexual encounter when a condom was also used. So again, contrary to science, but still, 25-year sentence for that. A man in Texas was serving 35 years for spitting at a police officer, a 19-year-old, so this impacts young people. Even I think the age of some folks who may be on this call, particularly we have a number of students, law students and otherwise, charged with intentional HIV exposure for a consensual sexual encounter with another student. Then a 23-year-old man in Oregon sentenced to 87 months in prison after pleading guilty to unprotected sex without disclosure of his HIV status to a partner that he met online. So again, these are just the examples. I want to just also give some of the science also just around what are the estimates? What does CDC specifically say around the estimates for HIV transmission risk? And it really depends on the type of exposure that a person has. When we think about blood exposures, particularly, I'm going to focus in on the top one on this graph, blood transfusions. We see there's a very significant risk of transmission based on exposure. So there's a 9,250 kind of chance per 10,000 exposures of HIV transmission from a blood transfusion from blood that is from someone who's living with HIV. And so that's a very, very significant kind of risk of transmission. Still not 100%, but a very significant risk of transmission. For all the other kind of types of exposures, we're looking at significantly less risk. So when we think about sexual risk, so the next highest category of risk would be receptive anal sex, so being the bottom, and a sexual encounter is 138 per 10,000 exposures. So if we're thinking about that in terms of a percentage, it's really just over 1%. So even that is not a guarantee and very low risk in a lot of cases when you think about it. And this is the highest risk kind of sexual behavior for HIV transmission. Still only about a 1% chance really for from a given exposure. And then when you look at other types of exposure, so insertive anal sex, so being the top, for instance, it's 11 per 10,000, so about 1%, or about 0.1%. And then even significantly less for vaginal sex. CDC says the risk is low for oral sex, and low is, I think, just the term. I mean, they don't usually say zero, but it's low risk. And then even below low is a negligible risk. So things like biting, spitting, they can't even be quantified, but they have really no risk of transmission. And again, these are risks even when, without taking into account science. So without taking into account people being on treatment, being virally suppressed or having an unprotectable viral load, as I mentioned, which means there's no chance of passing the virus onto a sexual partner, using things like pre-exposure prophylaxis, PrEP, or condoms. So the Department of Justice in the United States has worked in the past with the CDC. They worked to publish a journal article in AIDS and Behavior in 2014. And later that year, DOJ issued some best practice guidance for states to modernize their HIV criminal laws and set forth the current science of HIV transmission. I think this is so valuable. It's an important resource. And I'm hoping that obviously, going forward with DOJ, we have also a new administration coming in. Hopefully we can see more action and more work from DOJ, also working with CDC to give guidance to states and to really move forward with more evidence, reforming laws to make them more modern and consistent with the current science around HIV transmission. In terms of the best practices that DOJ laid out, they pretty much recommended that states eliminate HIV-specific criminal penalties in all but two cases. One case is where a person living with HIV commits a sex crime, where there is the risk of transmission. So that's engaging in having rape or other sexual assault, so without consent, and doing so in a place where there is a risk of transmission. That would be a place where states should, could consider to continue to have their HIV-specific criminal penalties. The other is when an individual who's living with HIV engages in behavior that demonstrates that they have an intent to transmit the virus, and that behavior that was engaged in has a significant risk of transmission, whether or not transmission actually occurs. Still, this type of, these requirements are significantly more than, as I mentioned, what currently exists in many states, which are just, you need to disclose, and if you don't disclose, regardless of what behavior, you could be criminalized. So just giving some impact from research on these criminal laws. Well, there's no evidence that HIV criminal laws deter sexual risk behavior. We don't see any differences between sexual risk-taking in states that have HIV-specific criminal laws and those that don't have them. One reason could be that a lot of people just aren't aware about how these different laws function. These laws also send inaccurate messages about avoiding sexual partners with HIV. So they send the message that that is an adequate prevention strategy. It's not. We have effective prevention strategies. Those are things like treatment as prevention, so U equals U, as I mentioned, PrEP, condoms, syringe services programs. Those are the types of prevention strategies that we know are evidence-based and that work and that we need to focus on, and we need to have messaging around, and not focusing so much on implementing, enforcing, and keeping the criminal laws that exist. And we know that studies show that there's an association between HIV criminal laws and increased stigma, and that stigma also has really negative impacts on health outcomes, particularly around HIV. So just giving some efforts, some changes that have happened. I'll focus in first on just California, because this is a place where we had some really great evidence prior to, around what criminalization looked like in that state prior to reform that happened in 2017 and became effective in 2018. So prior to that reform, California had 4 HIV-specific criminal laws and also a non-HIV specific law that criminalized exposure to any communicable disease. So not just HIV, it included things like hepatitis and other infectious diseases. You can see on the slide what those are, so I won't go through each of those, but we saw prior to the reform of these laws that over a 16-year period, 800 people and almost 1,200 different instances came into contact with law enforcement as a result of those laws. And really one of the big findings that came from research into how these laws were enforced. This all came from the Williams Institute, which is a research center at UCLA. From the Williams Institute's work, they found that 95% of all HIV-specific criminal incidents involved people engaging in sex work or people who were suspected of engaging in sex work, which is a really profound finding. I don't think that is how a lot of people think the laws are being used. I think we probably aren't thinking about it in the context of sex work. We're thinking in terms of individual behavior with your girlfriend or boyfriend or someone you hook up with online. But this is often how these laws are used to really target the most marginalized, and specifically who. We can see more from the Williams Institute data, and we've had other studies outside of the Williams Institute in other jurisdictions, and the Williams Institute has also done similar studies in other states like Georgia, Florida, and Missouri, and have found some similar results. It is important to look at the specific states, but we see kind of disparities. And one of the big ones is around demographics. So in California, we saw that the vast majority of HIV criminalization occurred within one county. So within LA County, 57% of criminalization took place there, even though only 37% of people living with HIV in California were in LA County. So it really depended on where you were located, what the prosecutor's office was doing in that particular state. And in terms of the populations who were criminalized, disproportionately women. So 43% of the defendants were women, even though when you think about people living with HIV in California, women made up about 13%. So that's a disproportionate impact on women, and also very much a disproportionate impact on people of color. So 67% of the defendants were Black or Latinx, even though Black and Latinx people represent only about 50% of people living with HIV in California. You see exactly how the charges kind of resolve themselves. Sometimes they were for an HIV specific crime. Sometimes they were for a non-HIV specific crime. So again, there was a non-HIV specific statute that was a misdemeanor statute in California prior to the reform. And then we also see evidence of discriminatory enforcement. So white men were significantly more likely to be released and to not be charged. So I mentioned the change that happened in California starting in 2018. Just want to quickly say what that was. It significantly reduced the length of a prison sentence or imprisonment that a person could face. So provided for imprisonment for no more than 6 months. So just making things more proportional and less severe. And so you could face that prison sentence if a person with an infectious or communicable disease, so this law is not HIV specific anymore, it kind of applies to any communicable disease. If that person engages in contact with a substantial risk of transmission, so really focused on substantial risk, and that's evidence informed as to what is substantial risk. That person has to have knowledge of their disease, so they need to know their HIV status or other health status. They have to have the specific intent to transmit the virus. So again, the focus is on specific intent. So not just living with HIV and having sex. You have to live with HIV, have sex, and you have to have the specific intent to transmit the virus to your sexual partner. There has to be no knowledge on the part of your partner, the exposed partner, that you had HIV. So again, if your partner knew you had HIV, if you disclosed your status, you wouldn't be criminalized. And then there also has to be transmission of the virus or of another disease to the person. And although in California, this last requirement, the fifth one around transmission, is not necessarily always required, because if that is not met, you could still be criminalized as a misdemeanor for a smaller up to 90 days of imprisonment. But still, in totality, all of those factors, I think, make for a better statute. And so I think they make it a lot more specific, more evidence informed, and hopefully reduce the chance of abuse of these types of laws. One other just thing to note is that the law allows for considerations of things like condoms, medical treatment. So for instance, if you're on treatment and you're virally suppressed, and any other types of risk reduction that can help to show that you don't actually have the specific intent to transmit. the virus. But I think this is very important. If you didn't take any of those risk reduction measures, that in of itself is not sufficient to show that you had specific intent to transmit the virus. So having language like that, I think, is also very helpful. Just going to quickly talk about a few other states. So Colorado never really had a law that criminalized non-disclosure of HIV, but they did have a law that provided for sentence enhancements for someone living with HIV if they were convicted of a sexual assault crime. And they also had a felony statute for someone who engages in sex work, knowing that they were living with HIV. So that was the previous laws that existed. The law was changed through a bill that was introduced in 2016 with the support of the HIV Decriminalization Task Force, later renamed the Colorado Mod Squad. So they introduced that bill, and it was ultimately signed into law. It eliminated the felony offenses involving sex work and HIV. And even though there was still in a sentence enhancement, it reduced the length of the time of that sentence enhancement for cases of sexual assault. And really, I just want to take away and obviously have us learn as much as possible from these prior kind of decriminalization efforts. Some big takeaways are around just kind of how we frame these issues. So really taking a public health frame. So this wasn't just a bill that was focused on decriminalizing HIV, but really just modernizing the public health infrastructure in the state. And so framing things around how we can promote public health, I think can be really key, particularly on kind of issues that can be more controversial. Engaging people living with HIV, making sure that people living with HIV are part of the advocacy, part of creating the statute, part of making sure this gets to the finish line and changes in a way that meets their needs is so critical. Fostering bipartisan allies. I mean, many states, including Colorado, are states where they're more purplish, and or they're going to have folks who are going to not just be Democrats, they're going to be relying on to get the laws passed. They're going to have to engage Republicans, and so engaging bipartisanly and having champions and folks to kind of sponsor and support this legislation, I think, was very key. And then more broadly, just building support with allies in public health, so with health departments, with HIV organizations, and communities as well. And then as lastly, I want to mention Iowa and North Carolina. So Iowa was actually the first state to reform its HIV-specific criminal law. It took many years to get to that reform, but after 5 or so years of advocacy, the health department took some action starting in 2010. They proposed some technical changes to update outdated language in the criminal statute. They took a position to support the concept of reforming their HIV criminal law even before there was a bill in the state legislature. They engaged experts and also developed their own kind of departmental kind of resources and fact sheets. Ultimately, the reform there passed in 2014, and that reform was crucial for reducing the amounts of punishment, focusing really on intentional transmission without a partner's knowledge, and introducing a tiered system. So there can be certain sentences for intentional transmission, for reckless transmission, for instance. And then in North Carolina, which is one of the more recent states to reform its criminal approach with respect to HIV in 2018, this was a change that happened through regulation, but the health department changed the regulation to say that a person who's virally suppressed for at least 6 months no longer has to inform their partner about their HIV status. And that a person who has HIV and is no longer legally required to use a condom is no longer legally required to use a condom during sexual intercourse if they meet one of the following conditions that's listed on this slide. So if they are themselves virally suppressed, if their partner is taking PrEP, or if their partner is also living with HIV. This is our last slide on HIV criminalization. Just really to take into consideration just what is the best type of reforms. I mean, unfortunately, we have a case where a lot of our criminal laws are based on some assumptions that just living with HIV in of itself is a significant risk of transmission. We know that that's not always the case, obviously, from all the science I've mentioned already. We know that U = U is the case. But even with kind of thinking about things like U = U, some have cautioned that reforming criminal law simply to exempt people who have an undetectable viral load is not really the approach that we may not want to take. In particular, folks have argued that this could exacerbate discriminatory impact of laws, particularly on Black people, other people of color, low-income individuals, transgender individuals, and sex workers, and other populations as well. Because when you think about just, again, disparities, not just in HIV incidents, so when we have new cases of HIV, but also in terms of health outcomes, we see major disparities, particularly by race. So Black people are less likely to be virally suppressed or to have an undetectable viral load, as are a number of the other groups that I mentioned, who are often the most marginalized folks. And those folks in many cases are often the ones who probably come in contact most with law enforcement, are most likely to be criminalized generally, but also for HIV. And so by leaving those folks out, we could see significant disparities in terms of who, even greater disparities in terms of the impact of the laws that are on the books. And so we need a broader approach. So approach that, again, takes something closer to what like Iowa and California did, while you have multiple requirements, including specific intent in the law. So that is, I think, a pretty detailed overview of HIV criminalization. I want to now switch, and I think we'll see some very similar things with COVID criminalization, or how that's come about in terms of policing. So, pretty much since the beginning of this pandemic, earlier this year, law enforcement has been engaged in ticketing and arresting individuals for not following COVID-19 stay-at-home orders or shelter-in-place orders. And there have also been arrests for people not wearing masks, and disproportionately, those actions have been taken against Black folks and Latinx folks. And even more recently, we've seen particular arrests and charges of folks for assault. I won't go through all of the examples on this slide, but these have been compiled, and you have some of the sites for to find out more about what policing is happening in different communities. And specifically, I want to highlight some work that's been done globally by Amnesty International. So they released a report earlier this year, and then also there's a COVID-19 policing project in the US that released this Unmasked report. So those are great resources to see exactly what criminalization and policing has looked like in the context of COVID. It seems like from all this evidence, from these reports and others, that this pandemic is really being used as a reason to expand police power and to marginalize and stigmatize and criminalize populations, and particularly, again, a lot of the most vulnerable populations that I've already mentioned. And so rather than investing resources in public health programs that I think could be very effective, again, we're going to need to build the evidence base around this, like we've seen in HIV, but I think there are lots of parallels. Rather than taking those approaches, people are facing police contact, and in some cases, and probably many cases, violence. When you think about Black Lives Matter, who are the folks who face violence when they're coming in contact with the police? Disproportionately Black people and other people of color. So when you're policing the way that is happening, that can happen, which obviously has many consequences for folks. But then people also are taken to jails and prisons, where they also are put at risk for COVID-19 infection. I'm gonna have two graphics from the Unmasked report that I mentioned, just looking at racial disparities. They're very significant, and it's so great to have this resource out there to show what the disparities we're seeing. So Black, Indigenous, and people of color are 2.5 times more likely to be policed and punished for violations of COVID-19 orders than white people in the United States. And when you just look at this graph, you see 34% of COVID enforcements are against Black folks, even though Black people account for about 13% of the US population. So a disproportionate impact, and important to monitor that, and to really make sure that we are centering how this is impacting particularly Black and brown communities. And then here's just a map of COVID enforcement by race, which also shows again, you see the orange color, which are enforcement against Black folks. Those are the biggest dots. So we're seeing a lot of enforcement against Black people. And again, enforcement looks different in different parts of the country. And it's important to monitor what that looks like. And this is, I think, a very helpful I think, resource, a map to show where the hotspots are for this type of criminal enforcement. So really just the takeaway on criminalization, like what we're seeing with HIV. There's lots of concerns that this type of an approach is going to be counterproductive to public health. And so when we're thinking particularly about COVID-19, we want to be shifting our conversation to what people need to be able to follow public health guidance. And so we really need to be creating environments where people can get tested and they can access the services that they need in a safe way. And specifically, what are the things that they need? It's important to provide information and education. Housing is key, and is key for so many health outcomes, but particularly for COVID, when you have to stay at home. If you don't have a home, how can you stay someplace? How can you, distance if you don't have a place where you can go to? Or if you have a home where you live with 10 other people, that's going to cause other risks. And so people need to be able to have a place where they can go. So we need housing assistance and supports. We need employment protection so that if you have to, quarantine for weeks at a time, that you still have a job to come back to. We need income support so that folks still have the income, so they can still live and eat and to have a life. We need things like safer child and elder care, and assistance with things like grocery deliveries and medication deliveries in cases where, again, you're quarantining or isolating. And then I think there's also just a need for creative supports to really break down isolation. Again, COVID has so many impacts, including mental health impacts. Folks are, not being able to connect in the same way with people. We need to support, addressing those issues while, supporting people to maintain distance, particularly as we see increasing rates of COVID. So we've covered kind of criminalization of HIV and COVID-19. So thinking about health statuses. I really, I'm trying to pack a lot of here, so I'll kind of not take as much time with these other issues, but I want to give a lot of good information, and there's a lot of good advocacy happening, particularly around sex work and overdose prevention sites. So I want to take the next 10 minutes to kind of go through these issues and then open it up for discussion. And again, want to take the time for folks to, again, ask questions in the chat. And I'll also, be able to unmute folks once we get to the discussion if you raise your hand or otherwise. But when we're thinking about criminalization of sex work, I think we want to just get everyone up to speed around terminology and definitions. What is sex work? Well, in the broadest sense, it's the exchange of money, goods, or really anything of value for sexual services. It's an umbrella term that encompasses different forms of sexual labor. So there are folks who do street-based sex work. So those are folks who are, out on the streets, who, meet their partners, either they come up in cars or walk up, like they're meeting them on the spot. You have folks who do online sex work, so maybe on different online platforms to meet partners. I think at least in the US, I think I'm sure many people on this call are aware of kind of recent changes in federal law, so SESTA FOSTA, which changes and regulates online platforms where people could be meeting folks for sexual exchange. SESTA FOSTA has really led to a crackdown on many of those platforms that have shut down since the passage of that law. So it's made it harder for online sex workers to kind of meet people online. And so that it's often just led for folks going to street-based sex work where they often might be more vulnerable to violence. But yeah, people meet online, they meet in brothels and other settings as well. And then in terms of sex work, that is the term that I use. I think many advocates of sex workers use, and sex workers generally prefer this term to really reinforce the idea that sex work is work, and to allow for a greater kind of emphasis on labor rights and the conditions of their labor and the protections that kind of are needed in that context. Sex work is not the same as trafficking, even though those two terms often get conflated. Human trafficking refers to using force, fraud, or coercion to induce someone to engage in forced or exploitive labor, which can be in the context of the commercial sex trade. But that is different. Sex work, which is, when we're thinking about the exchange, the consensual exchange for sexual services, is different from forced and coerced human trafficking. And so they can't happen separately. Sometimes there can be, overlap, I would assume, or you can lead into one leading into other. Sex work kind of can lead to being in exploited situations. But for many, many people, sex work is an independent thing, and it's something that they do for a variety of reasons. So it could be just to gain better income. They like the flexibility of like the hours when they can work and do sex work. And some people do it because out of hardship. They find it difficult to get employment because of discrimination. That's definitely the case for a lot of trans individuals who face homophobia in employment, but also a lot of populations where access to education make it harder to get employment to make a living wage. Where folks who have a prior criminal conviction, it can be harder to get employment due to that. And again, if you are convicted because of sex work, once you have that, even if it's just arrest, once you have that arrest or conviction on your record, it just makes it, you get put into a cycle where it's harder to get employment, harder to get housing. And again, some people just engage in sex work because it suits them the best. And so it's the profession that they would just choose for their life. In terms of the legal landscape, again, criminalization exists. It's the norm in the United States, everywhere except for a few counties in Nevada, which take a kind of a legalization model where there are brothels. And some states, prioritize enforcement against customers or Johns, but still we see criminalization happening, and really this has a significant impact on sex workers themselves, both on their own safety and on their health. So just giving some of the data around that, we see that criminalization is bad for health and safety. There's this 2014 kind of study that was published in Lancet that found that decriminalization of sex work is really the best approach for changing the course of the HIV epidemic for sex workers. We could avert somewhere between 33% and 46% of infections over a decade. What's happened really since 2014, sadly, I mean, on the positive side, we've seen a number of organizations come out to call for a full decriminalization of sex work, starting with Amnesty International. And I've listed a number of other organizations, World Health Organization, UNAIDS, Human Rights Watch, Lambda Legal, et cetera. But we actually haven't seen much momentum. We haven't seen states in the US actually enact decriminalization, or even other countries. And in many cases, we've actually seen the implementation of kind of more restrictive approaches, so short of full decriminalization. So when we think about what are the approaches that you can take as an alternative to the status quo, which is right now full criminalization, so there are criminal penalties for sex workers and their clients and for third parties, well, we can have a partial decrim model that's kind of also referred to as a Nordic model. So it's a decriminalization of just the selling of sex, but not the buying. So in theory, sex workers are not criminalized, but their clients are. So that's what partial decrim is. There's full decriminalization, which is decriminalization of both the buying and the selling of sex. So that's getting rid of all criminal penalties related to sex work. And then there are legalization models as well, which usually have regulations where you might have to work in a brothel, get tested and things like that. Just from the research, we know that partial decrim and legalization raise a lot of concerns. So partial decrim kind of creates a lot of the same harms for sex workers and their clients as is under the current kind of criminalization model. We know from Canada that there's data saying, hey, their sex workers face the same amounts of violence, police harassment. They face rush negotiations where it's harder to negotiate condom usage and safer sex under a partial decrim. So when we're thinking about safety, we're thinking about health, partial decrim, at least from the evidence that exists, doesn't seem to be changing things that much from this, the criminalization model that currently exists in most places. We also know from legalization, although there can be some removal of barriers, legalization can create kind of a two-tiered system that pushes the most vulnerable sex workers to the margin. So maybe folks who don't want to work in brothels or might have harder times working in brothels in terms of meeting clients and making a gainful employment. People who might be living with HIV, where, again, if your HIV status is something that the state's testing or that they regulate, that could lead those folks to be pushed to the margins where they could still be criminalized outside of the legal regime. And so we do have significant evidence that full decriminalization has a lot of benefits. A lot of the evidence that we have around that comes from places outside of the US, so places like New South Wales and Australia, as well as in New Zealand, which have had decriminalization models for years. We also have some evidence from the US and Rhode Island, where there was like a legal loophole that allowed for indoor sex work really over a 6-year period from 2003 to 2009, where we saw significant reductions, 30% reductions in sexual violence against sex workers and a 40% reduction in STI, sexually transmitted infection incidents among sex workers. In DC, again, these are the decriminalization efforts that are happening, and I'm spotlighting two. DC is one that I'm very familiar with. So there are advocates that are pushing for decrim in the district. So there's a Sex Worker Advocates Coalition, SWAC, which formed in October 2016 to really promote human rights, civil rights, and liberties, as well as health and safety and well-being for sex workers, and really advocating for legal changes that focus on challenging the current decriminalization of sex work. There are over 20 organizations, and some may be on this call now, that are participating in SWAC, as well as folks, advocates, activists, and others in their individual capacity. I've been a part of SWAC, particularly supporting them around their kind of research, so particularly policy, legal research, since close to the very beginning. I think I joined in early 2017 to kind of inform, giving them evidence base and thinking through laws and policies, how those can be changed to impact health and safety. So that's in my own individual capacity, but SWAC has been doing amazing work. And they've launched a Decrim Now campaign, and really a lot of their efforts through that Decrim campaign is around passing this Decrim bill. And so they've got a bill introduced the last 2 legislative sessions, first introduced in 2017, reintroduced last year. Again, it would be full decriminalization, so removing all criminal penalties for engaging in sexual exchange. The bill still has not passed, but I think there's been some momentum over the years. And so there was a hearing that I think was very high profile that happened before the Judiciary Committee and the DC Council in October of last year that was focused particularly on decrim. I think there's momentum building and more education and awareness happening. We just had an election in DC. There are, I think, more DC Council members who are at least receptive to kind of continuing to move forward and thinking about this issue and the right approach in DC. So I want this to be centered on people's mind, particularly people who are based in DC, but even outside of DC, how you can inform some of this work and maybe even support SWAC and work with SWAC and or advocates in your own communities around decrim efforts. Again, this has been an effort that started long before 2017 and is still going. So it takes a while to kind of move the needle and to gain the momentum. But I think it involves all of us. And so I hope that as you see these types of approaches, strategies, advocacy that's happening, that you'll figure out ways to get involved. So decriminalization is also underway, or efforts are also underway in New York. There's a coalition that's Decrim NY that's also advocating for legislative reform. So they have a bill that, again, if passed, would decriminalize sex work in New York. And I just want to quickly spotlight just work that we're doing at the O'Neill Institute. We've been working with 2 DC-based organizations, so Whitman Walker Health, which is a federally qualified health center that has a long history of working on LGBT issues and HIV issues, as well as a sex worker advocacy organization, HIPS. So we've been working with them since 2017. We're about to release, I think, a really strong report that we hope will be helpful for education and for advocates who want to do advocacy, so they can kind of know what the effects of laws and policies are on sex workers in DC. And we offer policy recommendations that are informed by our own research, particularly research that included focus groups with sex workers and interviews that we did with various institutional stakeholders, so members of the DC government, legal experts, and victim services organizations. And so, I mean, one of the big findings, I don't want to preempt it, the report we're aiming for to come out on December 17th, which is International Data in Violence Against Sex Workers. It demonstrates an urgent need for reform for DC's prostitution and solicitation laws. So please look out for that. So see the bold here. A report will be released. If you've already signed up or you already get emails from us, you'll get it through emails from the O'Neill Institute. Please sign up to get our emails if you haven't already. And also to learn about the event that will be coming, that will be tied to the release of that event. So there will be some type of a launch event. So please look out for that later this month. And then last, I'm going to just talk about decriminalization of drug use. I think my major focus here will be on overdose prevention strategies, particularly overdose prevention sites, so supervised overdose prevention sites. We don't have them in the US yet, but we have some efforts that are on their way. So Safe House is a Philadelphia nonprofit that really is focused on offering a range of overdose prevention services. They've been working for years now and really just recognizing the serious need in Philly as we see the need in other parts of the country. Overdose prevention, overdose deaths have risen in Philadelphia by nearly 200% since 2019, and we've seen significant numbers of deaths in the most recent years. And so this has led to a public health response from the mayor, creating a task force, and also efforts from the Department of Health and Human Services to declare the opioid crisis in particular a public health emergency. So Safe House is seeking to become the first safe injection site in the United States. And it would be providing a range of overdose prevention services, including safe consumption and observation rooms, but also recovery counseling, education, also triage to HIV, hepatitis, and other services. And again, this would involve medically trained professionals, peer specialists, recovery specialists, social workers, and case managers, all kind of working together to provide harm reduction and overdose prevention. The legal environment, so again, when we think about the criminal environment, is very much ever present. So there's been this legal case, United States versus Safe House. So the US attorney filed a civil suit to declare that supervised consumption sites like Safe House violate the Controlled Substance Act. This was, I think, a very high profile litigation. It drew a lot of attention. It definitely caught my attention. And I think a big thing that I noticed is that it is a civil lawsuit. So I think there could have been actually criminal actions against the organizers of Safe House. They did not take that approach. So even though this is very much undermining the opening and providing these services at a time when they're so severely needed, it was a civil suit. How that suit ultimately came about was resolved so far, at least in the first court, the trial court, was the court ruled that Safe House is really focused on reducing drug use, not facilitating drug use. So it's not doing anything that would be prohibited by the Controlled Substance Act. The judge, though, however, has ordered a pausing and opening of Safe House, citing the COVID-19 pandemic. And there is a case that is pending in the Court of Appeals for the Third Circuit. And so we're waiting to get a decision from that. So again, based off of that civil lawsuit that I mentioned, the current status of Safe House is that it has not opened as of yet. And there are also other issues around just finding the right location. Obviously, there's often community push, community outcry, like not in my backyard. So those are also other challenges to kind of opening specifically Safe House, as well as overdose prevention sites in other parts of the country, and I'm sure around the world. This is a model, though, that has been taken outside of the US. We've seen them for years in countries like the Netherlands, Switzerland, and Germany. We have over 300 sites that are operating globally, and they've shown the public health benefits and the cost effectiveness of this approach. We've seen it in Canada as well. So even though in Canada it started a little bit later than in Europe, an overdose prevention site in Vancouver, Insight, has existed for 17 years, and they haven't had an overdose fatality, and they've seen a drop actually in the rate of overdose deaths in the neighborhood surrounding that site. And we're seeing innovative models still being implemented. People are trying things even in a context where criminalization exists. So I don't know if anyone saw the recent New York Times article about the man with a van in Scotland, really just taking it on his own to create his own unique solution. So doing mobile van services with safe injection. So having a van with seats and trays and biohazard bags, and also naloxone, which is for essentially the antidote for overdosing, so reversing an overdose. Just kind of doing that, driving around and going to sites where people can use this, and providing supervised kind of injection. So these types of mobile van facilities are innovative. They might provide an opportunity for providing these services in places where, again, like you may have objections from community members. So we need more efforts to implement these sites. Again, I just very quickly, overdose prevention is evidence-based. We know that it can prevent overdoses, it can reduce HIV and STI prevention, also can contribute to lower syringe sharing, connections to various health treatments and services as well. They are a way in which we can kind of reduce the amount of kind of public injection and or discarding syringes in public, and also prevent involvement in the criminal justice system. And then when we think in the context of COVID, we've seen actually kind of an amplifying of overdose deaths due to continued isolation, economic devastation, disruptions both in the drug trade and in health health and harm reduction services. Again, we're seeing more and more places thinking about and being, there are people are proposing pilot projects to do safe consumption sites or overdose prevention sites. So places like Ithaca, Seattle, parts of California. But right now we haven't implemented this model in the US. So there's a need for continued advocacy to implement overdose prevention. And again, this is just the last slide to say, when we're thinking about overdose prevention, we also need to be thinking about the broader issue of decriminalization, because one of the barriers to doing it is there are criminal laws. There's criminalization of drug use and drug possession. And so we need to decriminalize drug use as well. We know this reduces stigma, and we know that it can have significant health benefits as well. And I just want to quickly point out Portugal as a kind of a case study, that Portugal really was the first country to decriminalize the consumption of all drugs. They did that back in 2001. Again, even with that decrim, it's not going to be the silver bullet that changes everything, but it has had very profound health impacts. So the studies have shown that per capita social costs from drug misuse has decreased. We've also seen decreases in the percentage of people who are in prisons for drug violations. So this is an approach that has been taken in other places, and that we can be thinking about for the US and in each of our respective communities and countries. So that's the end of my presentation. I think we have about 20 or so minutes, so it took a little bit longer for questions. So I'm going to get out of the presentation mode. I think we still have, some people have had to jump off, but I think we have a number of folks who have already asked questions, which is great. I'm going to first, say that, okay, I'm gonna have some questions. I don't know, maybe I can try to unmute folks first of all. We'll see how that works. I don't think there are too many people. I'm gonna unmute folks. If you've already asked a question in the chat, maybe unmute yourself and maybe ask that question.
Hey, Sean, thank you for the great presentation. That was amazing. I have one question related to some of the statistics you have, and maybe you have the answer. I just haven't seen it recently. Do you have, for the people who have been subject to HIV criminalization, do you have an age stratification? Like we know predominantly sex workers, we know almost exclusively Black people with some other people of colored populations as well. But do you have the age stratification? Because that would really help us have future conversations around how we're going to support individuals knowing that it's okay to learn their status and seek treatment if living with HIV.
Absolutely. So yeah, so there is that data where studies have been conducted. So with the Williams Institute, I mentioned California, Georgia, Florida, and Missouri, they do break down the age information. There's also a study that came out, I think, in 2014, really focused on like the Nashville area in Tennessee, where they show kind of just the age breakdown as well as other demographic information. I think all of those things are key. So we're going to need more, I think, data like that, and we're going to need data really at the state level and really at a more granular level in terms of counties, maybe the different, the seats of, state senators or state legislators. Those are the folks who are going to be making these decisions. So I think the more data we have like that, and then we can also stratify by all of those demographic information is really key. Happy to share kind of the links to each of those reports so I can follow up with you directly and also just share it with anyone who is on this call so you can kind of look at those reports. And really, I think one of the key things here for folks on this call are how can we get more data like that? Like how can we and have that data be tied to advocacy efforts that are happening in communities so that communities can use that data in their own advocacy efforts. And so I know, again, I think the Williams Institute is still doing this work. The person who kind of led the first several reports, Amira, is no longer with them. But I think, if there are folks, if they can work together with folks in communities, I mean, that's when the data really matters the most. So them just producing reports just to produce them may not matter that much, but if they're working with advocates and advocates are approaching them in particular, I mean, I'm sure they've also approached advocates, but particularly advocates going to them and say, hey, this is something that's useful. And I think it very much so, it is useful. So I want to just kind of go through it. Let's see, who else has asked a question? So we have, I guess, Zola Bruce, who just mentioned the Sex Workers Project. So they provide legal services and advocacy, education, and media, and organize to build a movement to protect sex workers, particularly protecting human rights of sex workers. Several people have thanked me for this presentation. That's great. And I have also just put in other resources that I think, again, I did a spotlight on some of the things that I know and are some of the key efforts that are happening right now in the country. But there's amazing work happening at the Sex Worker Project at the Urban Justice Center. And so definitely check out some of their work. So we have Walt, who asked the question, are there any laws or regulations that require prospective blood donors to disclose conditions, so disclose their health status, HIV, when a transfusion has a significant chance of transmitting a disease? So I think first and foremost, we do test blood before when people donate blood. We do test, and so that's the primary, I think, kind of intervention for preventing HIV transmission. So just making sure that we test blood, and so in that sense, it kind of is like, why would we need to have this additional kind of criminalization of folks not disclosing their HIV status if we're already testing all the blood that people are donating? And so I think how I would be thinking about the kind of just how necessary are those types of laws and policies to have. And so I mentioned the law in California. So there were 4 different laws, in part to take into account this very situation. So, what about blood transfusion? What about sex work? What about all these different contexts? So instead of keeping that approach, what they did was they repealed several of those HIV-specific statutes for drug donation for different things, and they just created this one this one statute that is, again, now a non-HIV specific statute that really is focused on intentional transmission. So if there was a case of a transfusion or someone doing something to intentionally try to transmit HIV or through blood, that would be captured by the current law in California. And so I think that is an approach that seems to me make the most sense, but I'd love to get like a follow-up in case I'm misunderstanding the question.
And also there still are a number of states that do criminalize individuals who attempt to donate blood if they're HIV positive, even though there is this testing like what you were talking about. They screen the blood, low likelihood that you would transmit because they screen every single blood donation. However, there are a number of states that you can face felony level prosecutions if you donate. Jada Hicks, by the way, sorry. Just wanted to add that little piece as well.
Absolutely, yeah. So I agree. Yeah, I in case I wasn't clear, like those laws still exist. Similarly, like prior to California, they existed. So they do exist in those states. And what I think we want to be creating a movement for is to, again, modernize our laws, have them be evidence-based and that reflect the science, as well as reflect the practices in public health, which is testing of blood donation. So. Just a comment around adult consensual sex work as being healing, that it's safe, that people are open, that it's an empowering experience. I think that is so important. I think there are so many misconceptions about the reasons why people engage in sex work, but thinking about consensual sex work, both as healing and as empowering, I think is so critical. I think we have a comment just around the need to, the role that racism plays. And so if anyone has any questions about, again, addressing racism, particularly structural racism, and how we can really work together to kind of address that issue. And again, I think by pursuing decriminalization approaches, that is obviously a major racial justice issue, but other kind of efforts that are going on, I'd love to kind of hear that from folks. I mean, we can always end soon, but I think we have about 13 minutes or so. If people are doing work that they'd like to share, feel free to unmute yourself. I think one of the good things about the way in which we did it today was that folks can, after the presentation, at least unmute as well as share things in the chat. And I also just, I see new messages. I just want to kind of go through the ones that I couldn't see while presenting. Darby Hickey, who's an amazing advocate and who's worked very closely as part of SWAC, mentioned that continued criminalization of marijuana use isn't the result of federal intrusion, but really something that's been championed by the DC Council, particularly chairman. So I think that's important to note that even though I think there are some roles that the federal government has played, and that people probably, particularly in DC, have to make certain choices, knowing that there could be. I'll mute everyone real quickly. But we still have folks in DC, and I'm sure in other jurisdictions, who need education, and/or in some cases we need to work politically to see if those folks are really meeting the needs of the people that they're representing, to make sure that we have approaches that again are again evidence informed, that respect the dignity of folks, and that really protect people. So thank you, Darby, for that. So I think we've had at least 9 other.
I have a quick question.
Yes.
I have a quick question for the group. Yes. I just want to hear from other organizations who's doing work, I think, specifically to engage the Black and Latinx communities of individuals not living with HIV in these conversations. So obviously we want to have this conversation outside of the HIV sector to ensure that we are getting more momentum to moving in the appropriate direction from a public health and altruistic perspective. So I would love to hear who's doing this work to engage the BIPOC communities of people not living with HIV on HIV criminalization. Because I know the work that we're doing, but I would love to hear what other folks are doing.
So I'll let some other folks chime in on the chat. Hello?
Can you hear me? It's Oscar.
Hi, Oscar.
Hey, sorry, let me put on my camera real quick just to be fair to everybody.
Thanks so much for joining.
Oh, no, no problem. I've been listening, and now if I could just figure out the camera. Well, let's just run with this. Oh, here we go. What I wanted to say, sorry, I've been feeding my puppies, is I live on the U.S.-Mexican border, and so you can't get more Latino MSM than we do down here. We have a extremely high rate of HIV and of substance abuse, specifically crystal methamphetamine. And it's the #1 leading cause for all our new HIV infections in this region. It makes up about 68% of all new infections are caused by crystal meth. That said, to be honest, we're not doing much regarding criminalization of folks living with HIV in this region. One, because it has been a non-issue from the very beginning, 30 years ago to now. And we tend to, even though we're 1.2 million people in 22 cities in this region, it's the compadre system of, yeah, you might be the sheriff, but you're the nephew of my aunt's cousin or whatever. And so we can have those kind of conversations when people do get in trouble, which again is very rare. But honestly, for our communities, I would venture to say that this is true for almost all Latino communities in the United States, and including Puerto Rico, is that our concerns are so much more focused on poverty, the desperation of not having access to medical care, especially right now during COVID, and those things, and all the other comorbidities end up taking precedence. So there's not enough of us because we're really underserved, both medically and in terms of our HIV funding, to do much else other than put out fires constantly, nonstop, 24/7. So sorry about that, but that's my take on it.
Thank you for sharing, Oscar. If anyone else has a response to that or any of the other questions in the chat or any other questions they'd like to ask, I just want to go through some of the ones that we've received just around how do we get information to prosecutors and the police that arrest and charge people for crimes. Often, again, the law enforcement that they're doing, it's supposed to be in the name of public safety, but it often makes people less safe. So how do we build coalitions with those entities? I'd love to hear from other folks. I'm sure there are some advocates on the ground who are probably doing some work. I know the Center for Hiv Law and Policy, which is one of the main kind of HIV organizations kind of working on issues like HIV criminalization. They've been doing particularly a lot of work. It's an organization predominantly composed of lawyers or people with legal training, doing outreach not only to public defenders, educating them around HIV criminal laws and the science around HIV, but also doing outreach to prosecutors and even judges. I mean, can't really educate or train judges in that way, but you can give them information on the science. I know that has been a major focus for that organization, and I'm sure they're continuing to do that work. Other organizations may be doing the same outside of the HIV criminalization context. And actually, it's really just important that, again, as we're doing that type of coalition building, education, et cetera, that, again, we don't just think really in these silos. So not just around HIV criminalization, but thinking about, again, sex work, thinking about drug use, bringing all that stuff at once. And I think there hopefully could be ways for folks on this call and even outside of this call to kind of work together to, again, address all of these issues and to really kind of amplify these messages, particularly with members of law enforcement.
Hey, Sean, it's Darby. I could take a stab at a recommendation along those lines. I think that the first part there is like articulating what you would want to communicate to the prosecution or to police. What is the ask you would want to make of them? Because simply don't enforce this law or you're racist is not going to be the helpful ask, even as it might be true. And I'm just reflecting on that from a conversation I had last year with some activists in Chicago who had the opportunity to, who had been working on criminalization issues around sex work and who had gotten the opportunity to meet with a newly elected kind of more progressive prosecutor there, and who had reached out and said, we'd like to meet with you. And these are folks who are not used to interacting with that world. And so starting to develop what you would want to ask and developing those relationships, right? And so that when you have a longer standing relationship with a lawmaker, with a prosecutor, then you get some more legitimacy with them, and you can constantly be kind of pushing your message to them. And I think that's something that a lot of particularly grassroots groups and groups that I know, like Oscar's talking about, are constantly putting out fires. You might not have capacity to do, but if you do have capacity or try to build that capacity, then you help influence them when you're talking to them all the time, as opposed to only going to them when there's an emergency or a big ask to make.
Thank you, Darby. And I think that's very helpful, and really, yeah, I mean, it's definitely something that we all should be thinking about. And obviously it's having the capacity to do that, but I think having those relationships and then figuring out exactly what the ask is so key. So thank you for that. And I hope that at least one, I think maybe benefit of this type of an event, and hopefully folks are able to see each other's names, you know, again, write down contact information, share that contact information in the chat, and hopefully you are able to be resources for each other as well. So I think we have about 5 minutes. I know some other folks have to drop off. I want to just make sure I have a chance to at least go over some of these other questions. I know someone from Spain, so it's great to have people from all over the world kind of participating in this event. I think at its max, we had almost close to 50 people almost, so that's wonderful. In Spain, in blood transfusions, there's a non-direct discrimination because people who aren't living with HIV, because people with no HIV living with someone with HIV are excluded. So that is also, again, it's important to kind of look at the policies that are in your jurisdiction. And I think this is actually such a discrimination around kind of blood donations is an issue that I don't think receives enough attention, at least in terms of my work in the HIV community. I think we don't always focus enough on that. Obviously, there's so many fires and so many issues to work on, but there's so many areas of discrimination against gay men, against different populations. And so in this case in Spain, if you are someone who's living with a person who has HIV, that might just be in of itself a reason to exclude in that state or in that country. So we need, I think, more attention on that. And so I think that's definitely, hopefully, I don't know, for me, I think it's very helpful to kind of understand what's going on there in other parts of the world. Lastly, recent legal developments regarding decriminalizing those who have been trafficked, either labor or sex trafficking, and who may also be in the U.S. illegally. I don't think I'm the expert on this. I'm wondering, I'm looking kind of at Oscar. I don't know if he has any thoughts on that particular question, if there have been any recent legal developments specifically on that issue. Obviously, that's a population that I think is very vulnerable. I think you're unmuted if you're speaking, Oscar.
Sorry, I was having trouble with the mouse. What was the question again, please?
Just any recent legal developments regarding decriminalization, decriminalizing those who have been trafficked, so victims of trafficking, but who are also like undocumented immigrants. So how do we address
until the current administration changes at the federal level, everybody, including the trafficked, are sent back to their home country. Even if they were brought here against their will, even if they have every legal reason to apply for asylum, once you apply for asylum, you're sent to Mexico to wait on the other side of the border in an encampment. Whether you're from Guatemala or El Salvador, you're sort of dumped into Mexico. And once you're in that asylum camp, the wait for an asylum hearing is a year. So yeah, even those people those men and women and children who've been trafficked are more often than not sent back.
Yeah.
Even if they were on the way here, by the way, on their own and then got kidnapped, they're still sent all the way back.
Yeah, and so I also just want to say, for the report that we'll be releasing later this month, Whitman Walker and Hips and the O'Neill Institute, we look at the various kind of consequences, not of trafficking, but of sex work, arrests and convictions, and including I mean, obviously there's so many consequences for your health, for employment and housing, but also immigration consequences, and making sure that people are aware of those. The population that we interviewed, like sex workers, were predominantly, Black sex workers, which I think reflects many of the sex workers, and really the population of DC. So we did not have anyone who was, at least self-reported, being an immigrant or being undocumented. And so that is an area that we want to kind of have a follow-up to. We're still looking for additional funding for this collaboration, but really, making sure that we focus on immigrant experiences for folks who are engaged in sex work, and particularly the needs of those who are undocumented, because there are, once you have that conviction, that could be a grounds for removal. And again, I don't know the answer specifically around kind of folks who are victims of trafficking, and I definitely want to make sure that we focus on that population as well, because although trafficking is distinct from sex work, there are particular issues. We need to meet the needs of those populations as well. And so I'm going to definitely take that question and think about it more and see if that's a way that, as we consider future work around decrim, we're also thinking about, kind of these broader issues around trafficking as well. So, and many of those trafficking issues are, again, as your question points out, are not even sex trafficking. So. Again, I think we're now at the time. Thank you for taking an hour and a half to join for this event for the presentation. I hope that was helpful and informative. I hope that in my attempt to bring together these disparate issues, but are also very much related, to kind of have a continued conversation on this, it was helpful for you. Please be in touch. I think you have my email address. If you would like the PowerPoint, or if you just want to follow up with me, I'm here to be a resource. This recording will be there'll be subtitles, and it'll be put on, I think, YouTube and linked to our website, so you'll be able to access this and share it with others. And happy to share that afterwards once it's available online with all of you as well. So again, thank you for taking the time. It's been, I think, a really great discussion, and I look forward to being in touch with all of you. Have a good one.
Yeah, you did a wonderful job. You are amazing. We love you. I don't even know you, brother, but way to go. You a bad, bad man, and I love you, love you, love you, all the way, all the way. We got to bring the voice sometimes. We got to bring ourselves sometimes, and you are just amazing.
Oh my God, I need you
amazing.
Every day. I need you every day.
Every day, baby. Every day, baby. I don't know you, but I got you, baby. I got you. Keep going. Keep dreaming. It's beautiful. I love you, baby. Mwah!
Thank you so much.
My new favorite person.
Absolutely, you are my new favorite person. We need to keep that energy, and we need to keep motivating each other to keep the fight going. Thank you so much for joining.
Thank you very much. Bye-bye.
Thank you.